Hello, this is Dr. Dan Malone. We are going to do a short treatise here of hip injections on the various structures of the hip that are important to know for good patient care. These are all going to be ultrasound guided, and we're going to use the most common and easiest approaches to make your life and the life of your patients that much easier. It's a general overview. We aren't giving medical advice. This is a pretty typical disclaimer. So let's talk about the interarticular hip injection. So we're actually going for the hip joint here. And we, of course, before we do anything, must review the anatomy. You see the numerical key here and the structures here. The most important of these to remember are the greater trochanter, the femoral neck, number 8, the femoral head, the labrum. Those are the anatomic landmarks that we're going to use to line up this hip injection into the joint. Here's the probe placement. It is pretty much parallel to the course of the femoral neck. The joint lies deep to this, which is the iliofemoral ligament. With the probe positioned in this way, we externally rotate the leg about 15 degrees to get the optimal view. Now remember, there is a neurovascular bundle of great import running here medially. The longer the external rotation, the more externally rotated the leg is, the more lateral the vascular structures will be. So there is nerve, artery, and vein. So if you rotate the leg externally, these are going to shift to the left to some degree. Keep in mind that they're still going to be well out of the path of our needle. And the path of the needle, as you're going to see, is going to be this way. But this neurovascular bundle is going to remain pretty far medial to where we're operating. There is the blue arrow showing you the path of the needle. So it's going to come from anterolateral and go deep. We're going to aim for the border between 3 and 4. So right there at the base of the femoral head where the head meets the neck is our target. Here is a view looking from lateral to medial. The greater trochanter is coming out at you here. The femoral neck here is a bit foreshortened and hidden because we're looking at this straight lateral toward medial. And there's the hip joint. Probe placement is along that femoral neck. And this is the image that we see. There is the femoral neck here. Here is the femoral head. The bony acetabulum is here, the cartilaginous acetabulum is there. This hyperarchoic line is a combination of the iliofemoral ligament and the joint capsule, and as you can see, it extends a fair distance distal down the femoral neck, folds back around, and so that this is our target. This is within the joint space and will be our target. So the junction of the femoral neck and the femoral head is where we want to place our needle. These are another 2 diagrams, one animated and one numbered, of the important anatomy that we just went over. I should also mention that in this general vicinity is the lateral branch of the femoral profundus artery, which you sometimes want to look for with your Doppler to make sure that you don't put your needle through that. Our needle pathway is going to be basically upper right to junction of femoral head, femoral neck. The anatomic layers, if you will, are put in drawings here. And again, the most important of these is the combination capsule and iliofemoral ligament, which extends all the way down to here. And so all of this is actually interarticular. And as you see, the white arrow is going to describe our needle path There's our ultimate target. And this is a video of an actual hip joint injection, and you will see the needle traversing this tissue and the tip ending up here. Here's the tip of the needle. As you see, it's coming in. It's coming in. It is now here at the capsule. He's trying to pop through the capsule. He's not through yet. Pop. He got through the capsule. And there's the tip of the needle. There is no question at this point that you are interarticular. You are deep to the iliofemoral ligament and joint capsule. Here's the shaft of the needle. There's the tip of the needle. And the next video you're going to see is an injection video that you're going to show as the injection occurs. You're going to see this space open up as the fluid goes into the joint. And he's injecting now. You see this opening up. That's fluid going up within the joint capsule, so it's deep to the capsule. You'll just watch this again. You can see actually fluid coming in here and moving around, and that space opening up. That is a successful hip joint injection. This shows you the advantage of using the needle guidance software. You can see how incredibly easier to see this needle is when it is within this dotted line area where the needle guidance beam is being directed. So this becomes a much easier to see object, despite the steep angle that we're using to inject the joint. All right, so that was the hip joint. This is now for the greater trochanteric bursa, and if you're doing tendon procedures, these same approaches apply. So anatomy again. We're scanning at the greater trochanter. This is the gluteus maximus muscle. This is sort of an oblique plane over the trochanter. Here's the ultrasound image. This is subacute fat. This is glute maximus. This is iliotibial band. And this is glute medius and glute minimus tendons. As you see there, the drawing that describes all these various things. There is a bursa between the iliotibial band or tensor fascia lata and the glute medius tendon, depicted here in blue. And the bony cortex is the greater trochanter cortex. This is a transverse view of the cortex with these various other structures. We look now at the video, and you're going to see the hip being rotated. So the hip joint is, or the hip femoral head is rotating within the socket. This is the greater trochanter that is also moving, and you'll see the gluteus medius tendon attaching here will be moving as well. The iliotibial band up here superficially does not move. The glute maximus doesn't move, but the gluteus medius tendon attaching here on the greater troch is what's moving as we rotate the hip internally and externally. On this side, you see these various hip rotators underneath the faded glute maximus. Okay, this is an injection now. This is, again, a transverse look at the greater trochanter. Here is needle guidance software helping us see the needle. We pop beneath the iliotibial band and inject there. Some people like to go all the way to the bony cortex. Personally, I don't feel that's necessary. You can get enough dispersion of suspension by popping deep to the iliotibial band and injecting. These are short axis views, this being the gluteus minimus, this being the gluteus medius tendons. So they're coming at you in short axis. The piriformis muscle is a common area of injection for posterior pain. The piriformis muscle has its origin on the anterior surface of the sacrum. It then proceeds laterally and attaches on the posterior superior portion of the greater trochanter. So these three scanning planes are what we are going to use to identify the more proximal portions of the piriformis muscle. We'll go through these one by one. Here is the important anatomy. You've got the ilium intact in plane number 1, gluteus maximus, as you see here. Just deep to that is gluteus medius. The ilium is intact. We have not yet come far enough inferior to see this here, which is the piriformis muscle. This tendon attaches posterior-superiorly on the greater trochanter. And you really don't see that until you get down to this far inferior. Now we are longitudinal on the muscle. You see it here. And we go as far as the ischium. We don't yet have the greater trochanter in the picture. It's more lateral out here. But this level of scanning number 3 is what we want to see. Here it is, the piriformis muscle coming out from anterior, moving posterior over the ischium, and ultimately attaching here posterior superior on the greater trochanter. So the proximal portion of this is coming out from in front of the sacrum. It travels laterally right over the sciatic nerve in most people, goes over the ischium, and attaches off the picture at the greater trochanter. And with the way, of course, to get this to move is to flex the patient's knee and move the hip internally and externally, and that will tug on this and move the piriformis back and forth on this diagram, on this ultrasound picture. There's the piriformis muscle going over the ischium, coming out from in front of the sacrum. And now the hip is being internally and externally rotated. Here's the structure that's moving. That is the piriformis muscle here, ending up in the tendon a bit more laterally and off the picture, attaching to the greater trochanter. Now, the posterior hip. We're interested here in the origin of the hamstring muscles, which come off the ischial tuberosity with a conjoint tendon that is difficult to separate ultrasonographically. This is a longitudinal look, as the probe showing here, longitudinal look at the ischial tuberosity. These 2 or 3 tendons come off from a conjoint origin and travel distally. Here are, on the diagram, you see the conjoint tendon here, the glute maximus, and the subcutaneous adipose tissue corresponding to the ultrasound on the left here. And here's the ischial tuberosity, there's the conjoint tendon, and this is glute maximus. Remember now, this is a long axis view, so this is the anatomic sagittal plane. When we go to the short axis, or the anatomic axial plane, notice again, here's the ischial tuberosity. This is the posterior aspect of the greater trochanter. Now we're much further inferior. We're well past and inferior to the piriformis muscle. Here is the conjoint tendon, 5, 6, and 7, coming off the ischial tuberosity. You see these other muscles as labeled. And this is the area of interest, noticeably and importantly, close to the sciatic nerve. So when you're injecting these, we must be careful not to drift too far to get in trouble with the sciatic nerve. So here's an example of a transverse view. You see the needle coming in here. Now notice they did not use needle guidance software in this particular video, so the needle is harder to see, so we've highlighted it for you. And you can see the tissue moving here, but I do not recommend advancing a needle until you can actually see the tip. So I would encourage everybody to use their needle guidance software and know exactly where that needle tip is. This is the conjoint tendon and the target of this injection, depicted down here. And this is the same video, played over again with the injection. And thank you very much for listening. This concludes the session on injections of hips